Good morning, everyone. We'll just wait for another minute or so, and then we'll get started. Thank you for joining. Okay, good morning, everyone. I'm Samudra Gupta-Bora, Director of the Health Services Research Center, and welcome to the Health Services Research Grand Rounds. Just some housekeeping notes. So this webinar is being recorded and will be available to view from the UH-RNE Institute website. Please make sure that your microphones are muted throughout the presentation. If any technical assistance is needed, please contact RNE team, Nicole or Abigail Zona, who are on the call. If you'd like to ask questions, you can type them in the chat. However, questions can be seen by all attendees. If you prefer to submit your questions anonymously, you can do that too. And with that, I'd like to introduce my friend and colleague, Sarah Ronis. So Dr. Ronis is an academic pediatrician and health services researcher devoted to improving systems of care for low-income families and their children. An associate professor of pediatrics at Case Western Reserve University, her work leverages qualitative and mixed method approaches to incorporate the perspectives of multiple stakeholders into research efforts. Since 2019, Dr. Ronis has served as the director of the UH Rainbow Center for Child Health and Policy, also known as CCHP, where she leads implementation research and program evaluation for philanthropically funded clinical programs at UH Rainbow Babies and Children's and UH McDonald Women's Hospital, while also mentoring trainees in scholarly and QI efforts related to child, family, and community health in ambulatory and community settings. Nationally, she co-facilitates the activities of the Emergency Medical Services for Children Family Advisory Network, which aims to ensure that family representatives are meaningfully integrated into state and federal efforts to improve care of children throughout the emergency care continuum. Dr. Ronis earned a Bachelor's of Arts from Harvard College, Master's of Public Health from the University of Rochester, and her MD as well as PhD in Clinical Translational Science from Case Western Reserve University. Thank you, Dr. Ronis, for joining us. Over to you.
Thank you, Sam, for that introduction. I am very honored to be with you all this morning, and I'm excited to share with you some of my reflections on the approaches our team takes to integrate patient and family perspectives into clinical practice improvement and innovation. Before we get started, I do have some disclosures. As Sam mentioned, I am supported in part by the Emergency Medical Services for Children Innovation and Improvement Center, as well as the Pediatric Pandemic Network. Both of these are funded by cooperative agreements with the Maternal Child Health Bureau of the Health Resources and Services Administration. And I also currently hold research funding from the Clinical Translational Science Collaborative Northern Ohio through their Module E research program, which is funded by the National Center for Advancing Translational Sciences. I need to be very explicit today that I am speaking as a UH physician and researcher regarding UH work, and none of these federal agencies had any involvement in this presentation or my comments today. So this reflects my own thoughts and reflections on the work that I've been involved in over the last decade or so. So my goal for this morning is that by the end of this talk, you'll be able to define the concept of patient and family-centered care, as well as its relevance to health services research, that you'll be able to distinguish between the concepts of patient engagement in research and patient participation in research, and that you'll be able to list at least 3 methods to integrate patient and family perspectives into your own research efforts. But first, I want to acknowledge the incredible team that I have the privilege of working with every day at the UH Rainbow Center for Child Health and Policy. This is a group of profoundly dedicated public health trained researchers who have really truly dedicated their careers to helping us at Rainbow and McDonald Women's to, in the words of our former president, Patty DePompey, think thoughtfully about how the clinical innovations and programs we implement in our clinical settings impact health outcomes for the women and children we serve, their families, and our community in Northeast Ohio. Or as our program manager, Becca Boss, puts it so succinctly, at CCHP, we aim to help the teams we collaborate with understand what works, for whom, and why. And at this point, I should mention that throughout the slides, you'll see QR codes in the bottom right-hand corner, and those are links to either the paper or the web-based resource I'm discussing. So if you'd like to learn more about our mission and activities at CCHP, you can check us out on the web. So as I mentioned, I'm a primary care pediatrician by training and practice. And so part of my role on our team is to bring a clinical perspective to how we approach the design and implementation of our research and evaluation efforts. I absolutely adore this illustration by fellow pediatrician Jack Maple, who's at Boston Medical Center. I use it a lot in my talks because it so succinctly captures my own experience. So on the right, you've got a clinician with no time and perhaps inadequate support, faced with a seemingly complex patient, a stressed out parent, a mountain of paperwork, and a sibling and family context that has other issues that may or may not be addressed. So if that's me on the right, on the left, this parent might have been Chrissy Blackburn, who was one of my most influential early career teachers, and I really credit her with getting me started on this path for my academic career. Chrissy was the parent of a child with medical complexity that we saw often at Rainbow when I was in residency training here. She developed a training program called E-Team that coached pediatric trainees into better communication skills when working with families of children with medical complexity. She went on to become UH's first employed principal advisor of patient and family engagement. She organized patient and family advisory councils beyond Rainbow's walls to support other inpatient units across our system. And she took on several crucial national roles that elevated the influence of patient and family voice in value-based care efforts across the country. And we lost her much too young in 2022. Chrissy might have told you that in the parable of the blind man and the elephant, as clinicians, improvement specialists, researchers, evaluators, we are the blind men, addressing or making sense of only a single component of a larger system, while the patient and their family caregivers are the elephant with an inherent and integrated understanding of the whole. So our patients and families have a lived experience that is essential to our improvement efforts. And without a patient and family centered approach, we are all likely to just continue to stumble around in the dark. There are a number of formal definitions in the literature for patient and family centered care. I really like this one from the Institute for Patient and Family Centered Care, which defines it as an approach to planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships. It comprises truly four core concepts. So first, respect and dignity, that our work incorporates family knowledge, values, beliefs, and backgrounds into care planning and delivery. Information sharing, that families receive timely, complete, and accurate information. Participation, that families are supported in taking part in decision-making, importantly at the level they choose. And finally, collaboration, that families have the opportunity to contribute meaningfully to policy and program development, program implementation, evaluation, education, research, and care delivery. Or in the immortal words of notable disabilities rights activist Valerie Billingham, nothing about me without me. Patient and family-centered care is not a new concept. I hope it's very familiar to everyone who's listening in today. If we go back a full quarter century to the Institute of Medicine's seminal book, Crossing the Quality Chasm, patient and family-centered care is called out as one of the 6 core domains constituting high-quality care. Care that is safe, timely, efficient, equitable, effective, and patient-centered. It's also central to how the National Center for Advancing Translational Science conceptualizes the translational science spectrum. So on this figure, those of you who, like me, are involved with translational science know that we've gone from that linear spectrum from T0 basic research out to T4 translation to population impact to this more integrated model where patients and families are at the center. It's also important that the entire research institutes have been developed in multiple countries, explicitly to focus on patient involvement in the full research continuum. So the first was Involve out of the United Kingdom. This was a national advisory board founded in 1996 to promote research conducted both with and by patients. In 2020, that advisory council was reorganized and the responsibilities for patient and public involvement were assumed by the National Health Research Authority's Center for Engagement and Dissemination. Our own PCORI, the Patient-Centered Outcomes Research Institute, was founded in 2010 as part of the Affordable Care Act to fund and promote research guided by patients. And their aim is that research guided by patients will improve healthcare delivery and health outcomes. And then our neighbors to the north in 2011 founded the Strategy for Patient-Oriented Research. And again, with the explicit goals of shaping effective, sustainable, and equitable healthcare systems through direct patient involvement. So with that background, I want to share with you a little bit about how I think about patient and family-centered care, which at its heart is all about decision making, who's involved in the decision, what information is being used to inform that decision, and what learning results from the enactment of that decision-making process. So on this slide, I'm showing the learning loop for collaborative decision making. This was the end product of a scoping review process I undertook while KL2 scholar here in Cleveland. The goal of that project was to really try and unpack models for shared decision making in chronic illness that would account for the involvement of a child with special healthcare needs of varying developmental capacity, who often is approaching a clinical encounter in the context and with the support of their parent or other family member. I could spend the entire 45 minutes unpacking the model, but I do want to highlight a few key elements that are really foundational to how I think about the longitudinal evolution of care plans, outcomes of care, and the learning that results. Whether you're talking about management of a specific chronic condition like asthma or ADHD, which I see very frequently in practice, or even about thinking about system investments in clinical or programmatic innovations. So first, I'll point out that each decision is founded in the quality of relationship between the patient and family and the clinician or clinical team they're interacting with. Ideally, from the literature, this relationship is founded in mutual trust, in empathy and attunement, which Ron Epstein defines as a state of shared mind or mutual understanding. But in many cases, we find ourselves starting from zero, or kind of even behind zero, where one or more parties are bringing past adverse experiences that color how they approach that relationship. The relationship between decision makers and the type of decision that will be made is going to inform the style of that interaction, whether it's more transactional based on information delivery or more relational based on information exchange and articulation of constraints. And that's going to inform hopefully the extent of implementation of that decision and the learning that results. And then I think for me, most importantly, those outcomes are then going to inform how each party approaches the next decision or the next interaction. In preparing for this talk, I recognize that this model actually applies really nicely to quality improvement and research efforts also. So if you're involving patients and families in scholarly work, their interest or ability to even interact with an evaluation or research team is going to be grounded in the quality of the relationship they have with that team or with the institution that team represents, or with their experience with research and evaluation in general. That is, the decision on the part of a patient or family to contribute data, whether as a research study participant or whether as a collaborator who's engaging with the team around study question design dissemination, is going to be informed by those past experiences. And I think as evaluators and researchers and improvement specialists, we ignore that past history at our peril. In its simplest foundation, I think of patient participation and patient engagement as two sides of the same coin. So on the participation side, that reflects the more classic framework that the research or evaluation team is going to be doing the heavy lifting in terms of study design to ensure representativeness of recruitment and the generalizable of the findings that result. And because of that, patients who choose to participate may do so for a number of reasons. They're interested in the topic, they want to feel useful, they want to learn something that's important to them. They may have some satisfaction about contributing something that only their lived experience can really inform. They might even find it therapeutic. And as in any good informed consent process, patients and families need to know why questions are being asked, what is being done with their answers, why those answers are important to researchers. If we shift to the other side of the coin from a patient engagement framework, this is where the research team may take a step back, and patients and families have a much more active role in study design and study approach. There's a lot of literature about the theoretical value of a study that's designed with heavy patient engagement may actually improve translation of those study findings into practice, because at every step of the way, the study is designed to better align with family interests and priorities. And within the kind of the side of the coin patient engagement, what that engagement looks like can fall along a fairly broad spectrum. So at its simplest and kind of closest to the participation level, consultation involves obtaining input from patients and families on specific research issues. Involved kind of takes a step further, perhaps by convening an advisory board or other mechanism by which the team can work directly with patients and families throughout the project as questions or concerns arise to ensure that those issues and concerns are considered. Kind of moving further along the spectrum, in a true collaboration, patients and families are partnering on research decisions. And then moving closer to sort of the community-based participatory research framework, empowering is where the team is now sharing power and sharing final decision making and leadership of the project with their patient or family partners. I think it's really important to recognize that as you move further to the right on the spectrum, the process also requires more time and knowledge of all partners, and importantly also increases the risk of your project and may actually cause harm. So in 2014, so about 10 years ago now, BMC Health Services Research published a systematic review and meta-narrative analysis of the literature that to this day is one of the very few studies to specifically assess for documented barriers and potential harms of patient engagement. Their review included 142 studies, of which only 7 were randomized control trials and 103 were purely qualitative. So that alone tells you a lot about the state of science of patient engagement. And they identified 3 major categories of harm. The first, patient frustration, disillusionment, or even broken trust, particularly if timelines and expectations from the research team aren't clearly communicated and clearly understood by the patient and family participants or partners. A lot of concern around tokenism. So that sense that patient presence is checking a box without allowing for meaningful input, or asking an individual to speak on behalf of an entire population or entire community. And then particularly from the researcher side, concern around scope creep. So that by engaging patients and their involvement as part of their research design and development, that you would invite consideration of irrelevant community concerns and issues that would ultimately render the research infeasible. There are some strategies and some big questions that research and evaluation teams need to ask themselves when contemplating inviting patient input into their quality improvement or research activities. So first and foremost, do you have adequate time? Getting the more complex your team is, the more institutions, the more individuals that you're involving, the more time it takes to organize everybody. Do you have sufficient resources to support that engagement, including the ability to appropriately compensate patients and families for their lived experience? Um, One of the kind of short anecdotes that sticks with me really powerfully is one of our family advisors with the EMSC program. Like many of our family advisors in that program, is the parent of a child with special health care needs. And while she is volunteering as an advisor, her time is not free because for every hour that she spends on a Zoom meeting with us, she has to pay a skilled nurse $160 to supervise her vent dependent child. So it's not just that she's donating the time, she's actually donating her own funds or her own effort. And so being thoughtful about really fairness, if you're looking for lived expertise from patient partners, that you're compensating them and accounting for their missed work or other costs they may be incurring to participate or engage in your work. Does everyone involved have realistic expectations about what's being asked of them? So back to that risk of disillusionment or broken trust and what will come of their involvement. And finally, does the team actually have the ability to change course in response to patient input? Because there's no way to faster disillusion a family than to ask for their input and then ignore it or be perceived to be ignoring it. So with that background in mind, I want to use the middle section of the talk to share with you some very local examples of work that we at CCHP have been engaged in for the last decade as we've navigated this interplay between patient participation and patient engagement in our work. So a lot of our effort has been focused on the UH Rainbow Huja Center for Women and Children in Midtown, which opened in July of 2018. It was the result of a multi-year collaborative process to relocate the peds practice and women's health practice from the first floor of Rainbow to a more convenient and accessible central location for the community. That was the result of a very robust community advisory board involving individuals as well as organizational leaderships from across the community, as well as input from the key involved clinical teams. And ultimately, the goal for the Rainbow Center at the time of its opening was to provide a one-stop location for clinical services and related programs that address structural determinants of health that impact the health of women and children in Cleveland and Northeast Ohio. What that ultimately looked like was some typical clinical service lines, relocating primary care pediatrics, adolescent medicine, OBGYN and midwifery services, having on-site key ancillary services that the community had identified as having difficulty accessing other locations, such as clinical dietitians, dental services, eye care, OB ultrasound, retail pharmacy, outpatient laboratory services. Um, Making sure the building had space to support social needs navigation and community outreach, which is involved into a very robust program led by community health workers and supported by pre-health profession student volunteers. Making sure there was physical space in the building to support innovative care models, such as centering pregnancy, which is celebrating its 15th anniversary this year at UH. My current new favorite group program, Baby Cafe, which provides drop-in opportunity once a week for new moms who are breastfeeding to learn from each other and obtain peer support, as well as support from lactation consultants. And then making sure that the space and structure of the building would facilitate integrated mental and behavioral health care, which was another area of concern for the families that contributed to the center's development. Crucially, I think this part of the story sometimes gets lost, but we're very intimately aware of, no operational dollars were involved in the design, construction, or population of the center. Rather, it was funded entirely through new market tax credits and philanthropic grants, of which there were at least 13 different active awards supporting the center at its opening. And so as a system, we had a need for accountability of those funders. And our funders, not surprisingly, were particularly interested in the perspectives of the patients and families we were serving at the center. So CCHP, we were charged putting together those evaluation plans. We had several goals for how we were going to gather that data. In terms of the kinds of data we needed, we knew that we needed a mechanism that would allow us to surveil for community-based needs and clinical issues that were not otherwise or adequately captured through operational or clinical data sources. So from a screening perspective, from the screening ethics, you're going to screen for a condition that you have something you can do something about. But we also recognize there were likely to be emerging needs in the community. I would say utility and security has been one of them, that we might not have an intervention right now, but if as a health system, we know that that's an emerging need, we can either develop or advocate resources to address in the future. Second, kind of thinking back to the risks of patient involvement, we wanted to make sure we had a mechanism for representative patient reported feedback regarding experiences and outcomes of care at the center that did not tokenize individuals. Um, for context, the last stats I heard is on average, the Rainbow Pediatric practice, which is the PEDS practice at the center, will see somewhere between 90 to maybe 150 completed CGCAP surveys per year. We do somewhere between 110 to 160 encounters per day. So those CAP surveys are not exactly representative of actually what our patients and families are experiencing. We wanted to address the parent-child diet or whole family unit, recognizing that our operational or clinical systems are designed to track individual patients as they're through their interactions through the system and not easily account for the interactions that their siblings or their parents are having. And then with 13 different funding reports to put together, we wanted to have a streamlined approach to minimize respondent burden. So we chose at the time to start with patient input via participation in a research protocol. So starting on the participation side of the coin, and we did so for a few reasons. At the time, we did not have the infrastructure or resources in place to support a proper patient and family advisory board at the center. So we didn't have a pool of families with whom, as an institution, we had a relationship with that we could engage in that capacity. We also found that a human subjects research protocol provided robust structures by which we could hopefully avoid or at least limit the risks of patient involvement I mentioned before. So an informed consent process is a method to ensure that their appropriate expectations are set, that the patient and family member understands the purpose of the data collection, how their input will be used and shared, how to close the loop if questions come up in the future. By being thoughtful about our sample size and sampling approach, we aimed to avoid tokenism by not relying on only a few individuals to speak for all. And then research protocols are by definition bounded in project scope. So it helped us limit scope creep in this moment of sort of expanding data collection needs. Looking at the range and types of data we could turn to and the large number of programs and services for which we needed to efficiently collect patient feedback, we opted to start with patient-reported survey as a middle ground between more exploratory or open-ended qualitative approaches and more bounded quantitative assessments. So in developing the study, we applied a few design principles. Uh, Wherever possible, we opted for a strengths-based or positive frame, and we did so for several reasons. First and foremost, to acknowledge our deep respect for our patients' expertise in their own lives, and also to help with that relationship building, to support rapport with the team, because we knew we were going to be asking participants to spend 20, 30 minutes with us and potentially disclose some personal and sensitive information. Second, we aim to leverage existing instruments wherever possible. Because the Rainbow Center is somewhat unique within our health system, we wanted to have the ability to anchor our findings against regional or national trends. Third, we wanted to design our response scales wherever possible to overcome social desirability bias, particularly with respect to sensitive topics. So in practice, asking a simple binary yes/no seems intuitive and efficient, but it may actually invite underreporting of challenges. So using myself as an example, my house is 105 years old this year, and with the wild winter we just had, my house has developed some pretty gnarly expansion cracks in the plaster walls, and I've got a portion of the attic ceiling that's starting to fall. So if you ask me the binary version, I'm going to say true because overall, plaster damage notwithstanding, my home's in pretty good physical condition. But if you ask me on a 5-point Likert scale, I might actually say 4, because while it's generally in good physical condition, there is an issue that needs to be addressed. So in designing our survey instrument, we applied key takeaways from John Ware and Ron Hayes' seminal 1988 paper on measuring patient satisfaction. And wherever possible, we opted to use ordinal scales that had meaningful anchors and no true neutral. Fourth, we wanted to be certain that our approach was inclusive of respondents with low literacy. So we designed the survey to be administered verbally. And then finally, our implementation had to be pragmatic. We absolutely could not interfere with workflow in the practices. So this all came together as what we now call the Link Survey, which is an intermittent telephone survey of patients and caregivers ages 18 and older who attend a visit at the center for themselves or with a pediatric patient during our annual recruitment window. We actually conducted the first two waves 6 months apart in 2017, even before the building was open. That allowed us to collect baseline data prior to center opening and to explore whether there might be some seasonal trends in responses, which were only apparent for utility needs. So since the opening of the center in 2018, we field annually in the fall over a 6 to 8 week period. We initially started out with in-person recruitment and consent procedures, and then with the pandemic in 2020, transitioned to a remote recruitment strategy, which we've used thereafter. And we now recruit 2 samples. The very last question we ask in every survey is, can we call you again in the future? So each year we first reach out to those who participated for the first time in the prior year and said we could call them back. And then we mail invitations to a representative sample of patients seen in the clinic with phone follow-up. So the cross-sectional samples allow us to make year-over-year comparisons, while the longitudinal panels permit us to assess with in-person change in experience or perspective. And this approach has been very successful. We have an annual response rate that exceeds 60%. Um, the survey addresses a number of topics listed here, including family demographics, their relationship to the Rainbow Center, information about the child and their healthcare needs, about the adult and their own health and healthcare needs, families' experience of social determinants of health, their experiences of care at the center, and their experiences with and interested in specific program topics. And that list kind of swaps in and out each year depending on program needs from teams within the building. The very first question we ask in the survey is, what are the 3 words that best describe how you feel when you are at the Rainbow Center? And this is the word cloud that was generated from our 2024 cross-sectional sample. So in blue are words with positive emotional valence, red negative, the gold are neutral or unclear. And as you can see, there's lots of words with positive valence, but also some cues where families might be more neutral or negative about their experiences. Um, the survey allows us to understand from patients' perspective how and why they use the center, for what purposes, and differences between the practices. Allows us also to kind of map these trends over time. And the good news is we're starting to see an increase in the proportion of link participants who indicate they have continuity with the clinician they see regularly. We ask some open-ended questions used for direct feedback to teams about what keeps patients returning. So again, this is data from our 2024 cross-sectional sample, illustrating value to patients of the location and its convenience, their experience with center staff and clinicians, and the connectivity and sense of community that the center appears to be promoting. Also, as an illustrative example, it allows us to unpack for the practice's top clinical concerns. So this again is 2024 cross-sectional data now focused on the PEDS practice. And really notable, despite organizing the center to provide comprehensive services in one location, more than 20% of parents still reported unmet healthcare needs for their child, with their most frequently endorsed health concerns being their child's mental health, weight, nutrition status, and asthma. And that concern for mental health is reflected in differences in their ratings of their child's overall in mental health. I mentioned before that we leverage existing tools where relevant, and given that this is talk about patient-centered approaches, I wanted to highlight our inclusion of the person-centered primary care measure, developed by Rebecca Etz and Cleveland's own Kurt Stengy through the Larry A. Green Center in Richmond, Virginia. This was the result of some of the work that came out of the Starfield 3 Summit with funding from ARC and the American Board of Family Medicine Foundation. This 11-item patient-reported measure captures aspects identified by patients, payers, and clinicians as responsible for primary care function and its impact on population health. We adapted the person-centered primary care measure to accommodate a parent reporting about their child's care. And in 2021, we worked with Steve Zizanski, who was the original psychometrician for the measure, to assess to what extent the measure still functioned as intended with these adaptations in place that I've highlighted in red. The validation paper is linked in the QR code here, but importantly, we found that the original factor structure still held, though the relative importance of each of the components shifted as compared to an adult reporting about their own care. Notably, in a pediatric context, the shared experience item became the most difficult for families to endorse. Not surprising because most kids are healthy and don't have substantial needs, but also that became the most important discriminating overall experience. For the next 3 slides, I'm going to share data gathered from the 21-22 longitudinal cohort, meaning we recruited based on an encounter in fall of 2021 and then followed up with the same participants 12 months later. We saw that person-centered primary care measure scores at the center were high. So with an average baseline overall score of 3.65 compared to validation work across the country, where the average score is 2.99. At first interview, we observed no differences in summary scores between those with and without unmet needs related to housing, finances, or food. But those with unmet needs for healthcare less often rated their person-centered primary care measure highly. And that aligned with our observations regarding churn and parent-reported unmet needs. So focusing on the bottom right-hand corner on parents report regarding their child's healthcare needs. On the left is the proportion of parents who reported one or more unmet healthcare needs at first interview, such as accessing appointments, accessing dental care, filling prescriptions, obtaining therapies, securing durable medical equipment or health insurance. The red horizontal bar shows those who still reported one or more unmet needs at their second interview. Similarly, the horizontal bar in purple depicts those with no unmet needs in either. And in the middle, the curve in green are those who resolved their previously reported unmet need, and those in yellow who reported a new need. So you can see that relatively few families reported unmet needs for their healthcare in 2021. More did so in 2022 than those who resolved. Notably, we did not observe any associations in those transitions with demographic characteristics of the child or family. When we unpack those year-over-year changes in experience of care, while the overall score remained high, we did observe significant within-person decline in parents' rating of accessibility, which aligned with that reporting of unmet need for healthcare, and actually, in retrospect, was probably an early signal of access challenges related to staff shortages and changes in telemedicine services that continued into 2023 and are just now starting to recover. So I spent a lot of time talking about what adults are telling us about their own care and what parents are sharing about their experience of seeking fair care for their children. But what about youth themselves? I mean, we're at Rainbow, we care for kids and youth. Despite being based in pediatrics, it's taken us at CCHP some time to get to the point where we are positioned for youth involvement, as there are a number of regulatory and policy considerations when a team aims to integrate youth voice into health service delivery and improvement. So thinking about youth sharing their perspectives as study participants, under the common rule, minors are by definition a vulnerable population because they are potentially vulnerable to undue influence or coercion for their participation. And for those of us who are based here in Ohio, it's further important to recognize that anyone under age of 18 is considered a minor. There are no automatic emancipation for situations such as pregnancy or parenting, living independently, unless specifically ordered by a judge. So as a result, if we're considering including youth as study participants, we're limited to including only those youth who have a consenting legal guardian, unless that consent is waived by the IRB, and that can be a challenging standard to meet. What about youth as study partners or engaging youth in the study process? So the rules around this vary by institution, but here at UH, we do have to contend with some legal and regulatory challenges. Most notably that at UH, youth under 18 are explicitly prohibited from serving as study personnel. So that means youth under 18 may not participate in study recruitment, in data collection, and handling any PHI for analysis or dissemination purposes. So here at Rainbow, activities to consult or involve youth, that is where they're serving as advisors who are weighing in on particular decisions, are much more likely to be feasible than efforts that empower youth to co-lead research that is hosted by our healthcare system. So coming back to the link survey mechanism and how we might integrate youth perspective while working within those restrictions. So last summer, we piloted for the first time a supplemental survey mechanism that we're calling TeenLink, structured as an intermittent survey of teens ages 14 to 17 who presented for care at the UH Rainbow Pediatric Practice in the Rainbow Center with a accompanying legal guardian who could provide consent for their teens' participation in the study. So right there, I will just highlight that that requirement did bound our study population, as many older teens are authorized by their parent to attend visits on their own. And so if they didn't have an accompanying legal guardian with them, we could not approach them. Like our approach for the main survey instrument, we recruited based on an index visit. But rather than calling teens later to complete a phone survey, since most teens don't like to talk on the phone, we instead used RedCap to build a web-based questionnaire they could complete right there on their phone or on a tablet that the study team provided. For our pilot wave, our goal was 100 completed surveys over a 6-week recruitment period, which we did meet. Because parents were actively signing consent for their teens, we also asked parents for permission to contact them in the fall for main link. So in the end, in addition to our 100 teen sample for this pilot, we had an additional pool of 40 parent teen dyads who participated in both parts of the survey. In designing the survey instrument, we again aimed for a strengths-based approach. So in addition to input from the clinical and programmatic teams at the Rainbow Center, we also looked to extant tools such as the NAMI poll of teen mental health from teens themselves, which NAMI fielded in 2022. We considered elements from the Youth Risk Behavior Survey and from the National Survey of Children's Health, one of my favorite resources. Because we were asking teens to complete the instrument as self-report in real time, again, we need to be pragmatic and keep the instrument as concise as possible. And so we were very intentional in the survey revision phases regarding really being aggressive about eliminating any data that we could duplicate or obtain elsewhere. We really wanted to make sure that we were maximizing our opportunity with the survey to really get teen perspective on things that we didn't otherwise have information about. And then we worked with teen advisors from St. Martin de Porres, which is in the neighborhood, through one of their student organizations and with the support of one of their school advisors to help us revise the instrument itself, to make sure that the questions we were asking resonated, that they would feel comfortable answering those questions in a survey research context, that the kind of cognitive interviewing around the response options made sense to our teams. Just like the main instrument, we started with the 3 words question. This word cloud is not color coded, but the sizes hold. We saw some similar themes to what we heard from adults in the main survey around the center feeling safe, calm, and comfortable. But we also saw some difference, including much more prominent terms related to anxiety or discomfort. To help prioritize planning around programming at the center, we asked participants to rate which health-related topics they'd be interested in learning more about. The top 3 for our teens were information about how to transition to adulthood, particularly adult healthcare, looking for programming related to healthy lifestyles such as nutrition, physical activity, and sleep, and mental health and coping skills. Those 3 were also top 3 for their parents. But notably, about twice as many parents were interested in these topics than their teens. So this distinction is an important difference for our programmatic teams planning these services to consider as they approach how they're going to recruit and schedule and organize such sessions. It was also notable that less than 1/3 of the teens we surveyed were aware of where to go for help if they needed it in their community. And a similar proportion told us they felt disconnected or unsupported by their community. So this raises the question, how can we, as a health system, use this information to tackle those information gaps for the teens and youth we serve? So one strategy also launched in 2024 is Kids Rainbow, which is Rainbow's first youth advisory council. We launched Kids Rainbow with support from the PPN and the International Children's Advocacy Network, which provides infrastructure for youth advisory councils at children's hospitals across the US and abroad, including curriculum aimed at youth to help them understand biomedical research and quality improvement, and how they, as youth advisors, can be effective advocates. The mission of Kids Rainbow is to center pediatric voice in UH Rainbow's efforts with the vision that our initiatives at the hospital will be driven by the ideas and innovations of the youth it aims to serve. There are also opportunities for our advisors to explore health professions careers through complementary resources made available by SETI. And this year, the council has opted to focus on the topics of community engagement, food insecurity, and thinking back to our link surveys, mental health awareness and access. We have several Kids Rainbow Council members who are also serving on UH Rainbow's mental health clinical effectiveness team. And the council is currently preparing a mini film festival of short videos by youth for youth on these topics that they'll be premiering in April. They will also be contributing to the Teen Link instrument revisions that we're getting ready to turn to in the coming months. I think I've got about 5-ish minutes left. And so what I wanted to do to wrap this up is take a step back and share some best practices around how to engage patients as part of a research team. Similar to developing community partnered work, starting with organizations that are working in adjacent spaces to your focus can be really useful, because much of my work focuses on children with special healthcare needs. Family advocacy organizations such as Family Voices have become natural partners. I would also challenge you to be thoughtful about looking beyond your usual suspects to consider whose perspective has been missing in conversations to date. And I think one of the most important, potentially challenging questions to ask is actually how you articulate your ask of your potential patient um, advisors. So one of the family advisors from Oregon, who I've had the privilege of working with in recent years, shared this list with me. Um, from her perspective as a family advisor, this is the list of information she needs when weighing whether or not to engage with a project team. What are you asking your partner to do? What lived experience, skills, or characteristics would be important to inform the work for them to determine whether they would be a good fit? Are there, and then some kind of key logistics. Are there any travel or in-person requirements? What's the size and composition of the team your partner will be joining? How often will they meet? What are the expectations regarding activity between meetings? Who's the primary contact if questions arise? And then, as mentioned, being thoughtful about the timing of the ask. So making sure you're asking early enough that your partner can make important uh, input into decision making, but with a mature enough project that the ask is clear. And as I mentioned earlier, being thoughtful about balancing benefits against risks on all sides. Thinking back to expectation setting, it can also be really useful to formally assess your patient partner's interest and influence at each step of the research cycle. So this was an approach we adapted from the Rethinking Research Collaborative and applied it to our current CTSC-funded project, where after the first convening of the advisory group, we introduced the project. We asked each potential advisor to complete a short questionnaire that asked on a scale from 0, no influence at all, to 5, high level of influence, how much influence did they want for each of the steps of the study? So this target diagram reflects the responses from 5 of our advisors, and it was really helpful for me as PI because I would not have known otherwise how interested advisor B is in being actively engaged with writing and dissemination. So as we plan that phase of the project and we approach that point, being very intentional about following through on that request and part of the relationship. Interestingly, though, there actually is very little consensus regarding how to measure patient engagement at each phase of the research cycle, though PCORI has identified measurement of engagement as a high priority for future research. The good news is there is at least consensus regarding how to qualitatively report patient engagement in research. So this slide shows the GRIP2 short form, which was published in 2017 simultaneously by the Equator Network and in BMJ. The team completed a Delphi process involving 3 rounds of survey and 143 unique individuals to articulate what elements of patient and public involvement she reported and how at each stage of the kind of paper. And there's actually two versions of this guidance. This is the short form, which is intended for public involvement in any study. And there's a longer version that can be used when the study itself, now we're getting meta, is mainly about public involvement in research. Finally, I want to draw your attention to some other fabulous resources that our team has leveraged in recent years. If you're looking for a very concise, pragmatic how-to resource that walks you step by step through best practices in family engagement, in quality improvement or research activities, check out the Lived Experience in Healthcare and Health Systems Research Handbook that was published by the Children and Youth with Special Healthcare Needs Network. They also have a published set of standards around compensation of youth and family partners that I have personally found incredibly useful when crafting project and study budgets to ensure that we have adequate resources in place to properly compensate partners for their time and expertise. If you are working more in the operational space and are looking to integrate patient and family perspectives into your work, I would direct you to the Family Voices Family Engagement and Systems Assessment Toolkit, or FESAT. We've actually used it with the Emergency Medical Services for Children Family Advisory Network to identify gaps and opportunities as to how we as a program can more effectively engage our family advisors in quality improvement around pediatric readiness. It's also really nice because for each topic area, it actually has a organization of action ideas with the evidence base that goes along with each of those responses. If you have patients or families who are interested in contributing to your research but don't themselves have experience or expertise in biomedical research projects, the Porch curriculum is a really useful starting place. This is a free web-based resource developed by the Ontario Strategy for Patient-Oriented Research Support Unit with funding from the Canadian Institutes of Health Research. It includes 5 interactive models. Each are about 30 minutes, but are a really nice overview for those who are new to the process, or a great refresher for those of us who've been doing it for years. And then finally, if you really want to go down the rabbit hole, PCORI maintains and is continually updating its resource set for researchers. So a few final thoughts. Hopefully at this point, I've convinced you that patient and family-centered care is central to both quality improvement and clinical research efforts. That patient participation and patient engagement in health services research each provide meaningful input into health system learning. And I would just kind of give the advice to be thoughtful about expectations, timing, resources, and constraints when selecting approach is going to best fit your work. I would also advise you to be prepared to invest. Creating opportunities to connect with patients and families takes time. Developing some of that trust and attunement takes time. So where you can, identifying and reducing barriers to participation can be really useful, as can leveraging your trusted champions and navigators to help facilitate that relationship development. And then be comfortable with persistence. Small wins are still wins. Part of me is sort of feels like I got my face that it took us as long as it did to get to the youth advisory phase. But on the other hand, I'm really excited and proud of the team and really honored by the input from our advisors that we've finally made it happen. So yeah, small wins are still wins. And with that, I am happy to take any questions.
Sarah, thank you very much for this very comprehensive and informative and actionable kind of plan for us to engage our patients and families. Just a reminder to all the attendees that you can type your questions in the Q&A box. And while you're typing your questions, I will just take the liberty to ask the first question. I saw that you distinguish between engagement and participation, except that it was like a Venn diagram with some overlap. And I wonder if one comes before, or they're like really, is it engagement that facilitates participation, or am I getting it wrong?
I think it can go both ways. I think there, especially the push from the big national institutes and some of the qualitative literature that's out there, would argue that a study that is designed with thoughtful patient engagement will improve ultimate participation, because the questions that are being asked, the approach the team is taking in terms of who and how and where they're recruiting will be better aligned with what the average patient or the individual um, who's kind of not on this journey might resonate with them. I would also argue that, and we're seeing this in some of the CTSA funded work, that the active participation in a study can help you develop your future engaged advisors. So when even within our link survey mechanism, our response rates are high for both cohorts, but our response rates are higher for those that we're calling back for the second time. Partly because we now have an established relationship with them. They've gone through that process once. They recognize our voices on their phone. They remember that we had the conversation before. So it's familiar and less of a black box, particularly for those that may be a little bit skeptical about research with a capital R, or concerned about how their data is being used. So I think I think it can iterate both ways. And that's why I like the learning loop kind of conceptual model. And I think that individuals can also cross back and forth.
Thanks. There is a question here at the Q&A about UH migrating to Epic and how to use MyChart to capture patient-reported data to
Great.
understand physical and mental health.
Yeah, that's a great question. And honestly, from a clinical perspective, that's been transformative. Because as a practice prior to Epic, we were doing our mental health screening for our youth and young adults on paper, which meant the paper had to get to them, and then we had to review them and then get them back into the chart. So particularly from an analytic perspective, that data was difficult to access unless you had, which we have done, several research assistants and students spending a lot of time doing manual review. So across from a primary care institute, we now do a number of those screens pushed out ahead of the encounter through MyChart, or actually more often, especially with the mental health questions, completed on a tablet at the time of check-in in the building, particularly around some safety protocols to ensure that we don't have someone submitting a screen that's concerning for suicidal ideation without the ability to review and intervene in real time. Um, but from a program perspective, having that data synthesized in discrete fashion electronically has been fabulous. One of my other hats, I help run the Healthy Steps program at the UH Rainbow Center with Kim Burkhart as my co-PI. And so our Healthy Steps specialists are able to use those Epic tools to track in real time who's had a concern flagged on their SEEK, or their Safe Environment for Every Kid questionnaire, or on the maternal Edinburgh perinatal depression screen, to confirm that there was appropriate response in the moment, and then to do some follow-up with those families in real time, or kind of within a couple of days of the encounter. So yeah, using your data systems for good is super exciting.
Thank you. Sarah, I have another question. Are there any special guidelines or guidance or anything available for engaging hard to reach population? It's a group, obviously requires special effort. So are you aware of anything that could help us engage successfully?
I think it's a really, really important question, and I think an area of active inquiry right now. In fact, Tashiana Copeland-Smith, who's one of our fabulous project coordinators here at CCHP, and I had a long conversation about this yesterday, because I do think there's this tension between, especially if you're thinking from an advisor perspective, relying on your usual suspects who may be in a different socioeconomic bracket, or may have a different motivation or lens um, for providing their input compared to sort of the broader swath of the population that we aim to serve. Um, Again, I think some of the resources I shared late in the talk, like the lived experience handbook, has some really nice resources there. I think this is where, even if we're focusing on trying as a healthcare system to go so-called direct to consumer, or right to our patients, our community partners can be really helpful in serving as some of those gatekeepers. So on the women's health side, thinking about organizations in our community, like Birthing Beautiful Communities, who runs a community grounded doula partner program, or some of our asthma work, thinking about, our public health department, Environmental Health Watch, who again have a different relationship and a different access point and may be able to help facilitate some of those introductions. I think there's an opportunity for both and there, and I think it's something everyone, but especially large healthcare systems, are still trying to figure out.
We're almost at the hour, but I have one question that I'll just quickly throw it out there. How does health literacy play into this engagement and participation? Clearly, there is some association, and how do we factor in so that, people of all, I guess, literacy brackets have an opportunity to meaningfully engage and participate?
A really good question. And I think that is where some of these iterative opportunities or sort of low stakes or kind of low risk, maybe be a better way, opportunities for people to be exposed to the research process. We spend a lot of time thinking about how to convey sort of and combat myths about research. Um, One of the really cool opportunities we had as a team, gosh, 2 summers ago now, in collaboration with the US Rainbow Midtown Advisory Board as part of Midtown Opening Day, was to do some research data collection for the CAB. But the methods we used were very interactive. So building a word cloud in real time, having people mark on a map where they lived relative to where the event was, and then having the conversation that like you're participating in research and this is what research can look like. And so I think breaking down some of those myths, and then I think being thoughtful, again to use Patty's terms, about different approaches, whether it's a quantitative survey but we're administering it verbally, or we're providing opportunities to use some of the accessibility tools that can be built into web-based services for to use visual aids or other forms of communication beyond written.
Thank you so much. Thanks for a terrific presentation for a topic that's so relevant for us within health services research, but also as an institution and applicable to all research across the spectrum. Thank you so much. And thanks to all the attendees for joining us. We will see you in a few weeks with a distinguished speaker series. Thanks again. Have a great day.